So welcome, everybody. I am delighted to have you here to talk about data safety monitoring boards, such a fascinating topic for those of us who are knee-deep in them and obscure and probably dull as anything for people who aren't. But I'm figuring if you came, then you are in the former category. So uh, I am very glad you're here. Uh, the uh, just to give a little context on me, I have been doing work with DSMBs since 2003. I got invited um, to be on the NIMH DSMB, and I had no really idea what that was, but they wanted a suicide person, and I said sure, and then was on that board for about 20 years, and I'm still an ad hoc reviewer for them. I get sort of floated onto different DSMBs when I don't have a conflict, which is turns out I know a lot of people, so there's a lot of conflicts. So I have a lot of experience from that. I was sort of counting it up in my head, and I think I've had close to 10 data safety monitoring boards for my own research. And I think I've been on close to 10 DSMBs for other people's research, including I'm on one of the other P50 centers and do some work on a ketamine trial. So my early years on the DSMB at NIMH have served me well for being able to track what's going on in monitoring a mitigation trial. Since that was all it was at the beginning. It really took a while for psychosocial treatment to get absorbed into the DSMB system. And we'll talk about that a little bit. Just in terms of disclosures, these are my opinions, and they don't represent necessarily anybody who funds my research, including NIH, the Veterans Affairs, or the Department of Defense. And I will just acknowledge that I am a believer that people's time should be compensated, just like reviewers' time on grant reviews. And I do receive financial compensation for the time I'm preparing for and attending DSMB meetings through NIMH and when I've been on independent DSMBs. So just to put that out there. So I have a lot of content. Because I have a lot to say on this topic, this isn't actually everything, but um, I want to give a little history of IRBs and DSMBs. When I went to write this paper, that was one of the reasons I wanted to, part of it is I wanted to get the message, some of my thoughts out there, but also I was really interested in trying to understand the context. I'm a very context-oriented person. So understanding why did DSMBs come along? What is it about? Why do they do what they do? So I'm going to try to share a little of that with you fairly quickly at the beginning, talk a little bit about the internal and external functions of DSMBs and particularly good clinical practice guidelines and stopping rules, which I think are two of the bigger issues that we all contend with, and a little bit about sort of the differences between behavioral research and medical research, where I think is where we often get ourselves tripped up. And then I'll pivot to suicide research trials. What are some of the issues that we face with DSMBs for suicide research? And I'll conclude with the alternative DSMB charter that I developed with Greg Simon, and we've been using in our research at CSPAR and SCRC, and some tips for partnering with communities and thinking about regulatory work in the context of the communities with whom we're partnering, since so much of my work is pragmatic and effectiveness oriented and partnering with communities, and that sort of changes the dynamics quite a bit in some cases. So if we just start with IRBs, a lot of people say, like, why do we have to have a DSMB? We have an IRB. So why do we have DSMBs? It's a good question. So the idea of an IRB, right, is safety, rights, and welfare of the research participants and ensuring compliance with federal and state regulations and institutional policies. And they are focused on a single institution. So the only time an IRB will review for multiple institutions is that they're literally taking over review, right? There's a whole process of deferral of review, and a different institution that maybe has a peripheral role in a project can defer its review to somebody else, but then essentially that IRB is um, kind of that the referring organization or deferring organization um, is like giving up its responsibility, and the receiving organization is not really expected to speak for the organization for whom they've taken over review, if you know what I mean. That's part of the whole question of when you may have been caught up in at one point or another about like, are they going to defer? Are they not going to defer? Right? You really have to let go and just let the other institution kind of perspective guide if you're gonna. That's because that IRBs are very single institution focused. Um, and that means they're also they're pretty tied to local policy, meaning that university, that state, as well as whatever the common rule and the national guidelines. With multi-site research, however, what was happening was apparently the IRBs were getting inundated with individual adverse event reports that they could not readily evaluate because they did not have the context of the full trial, right? So you have something that's happening at 6 major academic medical centers, and it's only in the context of the whole trial that you can really interpret what does it mean that this person that we're having, an increase in AE reports for severe dizziness, or an increase in AE reports for nausea, right? Or for something more significant like we had a heart attack in this cardiac trial here at our institution. I can't and we know about our 25 participants in this trial, but there's actually 100 participants in this trial. I don't know what's going on with all of those sites, and I can't understand kind of how to manage this risk. So the DSMBs were proposed essentially to organize this information into a single report, and that report to the IRB would include the conclusion of experts. So that there would be a template that each institution's IRB would accept before the trial begins, and the DSMB would then use that template to review the project, come to an integrated conclusion about things that are hard for an IRB to determine, and then that report goes to the IRBs. It got started back in the 60s with what's called the Greenberg Report through the National Heart Institute. So the Greenberg Report called for 2 things that I think are, one is something we kind of recognize and some is stuff we don't. So the DSMB piece was the second point here. A policy board of experts independent of the trial to view and recommend changes to protocols, settle disagreements, and advise on removing or adding research groups. And the focus is the sponsoring institution, which in a case for like NIMH would actually be NIMH, right? But you could also have something that is, or it could be PCORI, or it could be VA. It would sort of depend on the larger context, but it's often speaking to your funder frequently. The other thing that snuck up on me was this idea of a coordinating center. This is totally common in medical and drug and device research, not what we usually do in behavioral health research. And when I had a trial that was being followed by the NIMH DSMB, and we were supposed to they kept talking about our coordinating center. We didn't think of ourselves as a coordinating center. And therefore we had no budget for a coordinating center, which is supposed to have its own staff person and its own methodologist. And we didn't have either of those things, mostly because we didn't think we were a multi-site study, because we were a study working across five different tribal communities, but not different universities, right? I thought of them as like sites, like different clinics in a study. That's not how NIMH decided to see it. So we were financially really struggling to meet these standards without any of these things being funded. So these independent policy boards, they become DSMBs, although I will note that in VA and other places, there's other names. So if you see other names for DSMB is not universal. So one of the things that I think is really important to sort of understand about DSMBs is you have to understand medication and device research. They are centered around this idea of toxicity, and DSMBs were very much tied to medication trials where you had to deal with the toxicity of the medication, right? And so they had this specific grade of toxicity in terms of what they're thinking about are their adverse events. And this is closely tied to the phase model, sort of like where you're having early phase research and then clinical trial research and then effectiveness research. And, you know, you have to get your mind around this. You want to think like some of these medications are seriously dangerous to people and can be seriously helpful. So think cancer trials, etc. And so when we're talking phase research and toxicity, some of those early phase trials involve determining the safety, and you wouldn't even use the people with the disease in your study, right? So if this is a study of this kind of cancer, you may start with healthy controls, right? Because the toxicity is such a central issue. Based on this toxicity level, we ended up with these two terms that many of us who do research are familiar with: adverse events and severe adverse events. So adverse events were really focused on toxicity of the medication: nausea, headaches, dizziness, etc. And they were considered severe adverse events if they were serious enough to cause hospital injury or death. Often the adverse events related to toxicity, this was considered critical because of kind of these two factors. One, that the toxicity is unrelated to the disease under study. Like you wouldn't get this nausea or this dizziness or this heart attack risk because you have the cancer that we're studying, and it wouldn't have even come up if you didn't get in this trial, right? This is simply not something that would happen to you except in the context of this research trial where we're trying to figure out if we can use this medication to save lives, right? So does this sound like suicide care research? No, this does not sound like suicide care research. So I'm just calling that out now, right? That the adverse events that we're monitoring are generally suicide related events that are related to the disease under study and would occur outside of participation, right? So just thinking right now about how different our world is from the world that this DSMB system was built on. If we like swap over to sort of behavioral psychosocial psychotherapy research, toxicity really wasn't a concept, right? There were few cases where negative effects were being identified. And so the field, as it developed, was much more focused on efficacy and not safety, right? So really, we were trying to prove that psychotherapy does something at all. We're not worried about it doing too much or doing the wrong thing. We're trying to figure out, is there anything even happening? And there are a few areas where negative impacts of psychotherapy were noted, right? Short-term increased anxiety from exposure, critical incidents debriefing, group therapy with adolescents with conduct and substance abuse disorder, having sort of deviant peer issues, right? But it's almost like these exceptions kind of almost prove the opposite, right? Like we're stretching to find these exceptions because by and large, we're really not in the toxicity. We don't really need to think about toxicity in the same way as medications and devices. So in 2004, there was a review that looked at a selected group of RCTs. Almost no psychosocial trials had what they considered to be adequate reporting of clinical adverse events or labs. It just wasn't anything people were tracking. But they also highlighted there are no standards for appraising safety. There in the medication world, there's lots of definitions of looked mild, moderate, severe toxicities. What are the standards for an adverse event, a severe adverse event? Um, and one of the things they pointed out, which I thought was really interesting, is that many safety outcomes for mental health may be impossible to disentangle from efficacy because mental health outcomes are often some kind of composite of benefit and toxicity. So I think an example of this U-shaped curve around anxiety would be a good example, right? We're not trying to eradicate anxiety. We're trying to get anxiety to this kind of peak point where you've got sort of the advantages and disadvantages of the phenomenon. And so I think it's really kind of we're just kind of in a different frame from the frame in which the system was developed. Okay, so that being said, let's talk about what DSMBs do. So DSMBs are generally focused around this idea of internal monitoring and external monitoring. So internal monitoring is when they're checking on all of the procedures and adherence to the protocol. Is everybody doing what they're supposed to be doing, essentially? External monitoring is when people are examining the data to determine whether there needs to be a change, such as a stopping rule, and we'll come back to that. So if you're doing internal monitoring with a lot of DSMBs, not necessarily your independent DSMB, but definitely at the, for instance, NIMH level, you need to understand this concept of good clinical practice. So I was like, well, that sounds like, first of all, clinical and not research. And second of all, sounds like what? Don't we all have good clinical practice? Like, what is this? So it turns out this is a standard of principles that was developed internationally by the internet at the International Conference on Harmonization to kind of kind of have an international frame on what are the standards for clinical trials. It was developed in 96, and that's when the FDA adopted it. And it's been updated in 2016, 2023. Actually, I think there's a 2025 update as well. And it kind of goes through all the responsibilities that everybody's supposed to do when they're conducting a clinical trial. Like I said, that because if you look at the sort of timeline of the development of DSMBs and the good clinical practice, the FDA adopting it led to there's kind of this intertwined nature of GCP and data safety monitoring structures that developed in medical and drug and device research at the same time. And it's sort of like HIPAA, right? There's the standards and the principles. And if you read those, you know, like you're not going to see surprises here, right? Like these are all the things we think we do all the time anyway, right? These are the 13 principles as of I think 2025. So I don't you'd think there was nothing new here. What the reason that we keep getting tripped up, I think, in DSMBs is that the FDA has this high level monitoring that is done in order to approve a medication for use in the across the country, right? And this is um, kind of driving the documentation of good clinical practice. So kind of how is good clinical practice getting operationalized? And just like HIPAA can be interpreted one way by Kaiser Permanente and a different way by Optum or St. Luke's or anybody else, you're going to see that the GCP documentation and the principles aren't necessarily the same thing, right? So because these medication device research teams, like they've evolved and sort of operationalized these principles, and they've organized their procedures based on these principles, and their operationalization of these principles has become the standard, right? Even if you go back and look at the standard and you're thinking, oh yeah, that's just what we do, the way that you're expected to do it doesn't necessarily look that way. The other thing to remember about FDA research is that the medication and device research teams are structured very different than behavioral health research teams. So they're generally led by career project managers, people who this is what they do is manage multiple trials, or they're part of centralized research centers like Fred Hutch, where they may be running, any given clinic might be running 25 different trials simultaneously, all following under a single research center. So that means that their operationalization of these procedures, there's a standard way of doing it that used in every trial, right? So individual physicians who are PIs of these studies, they're not organizing these procedures themselves, and they're frequently not the people carrying them out, right? Nurses are consenting, research staff are collecting data, et cetera, et cetera. But we do things really differently than that, right? So behavioral health researchers, such as psychologists, and I'll own that that's really my frame of reference, we tend to work on independent research. We're not usually embedded in research centers. CSPAR and SCRC have been, particularly SCRC has been a real experience for us of thinking about how do we actually centralize procedures we've never centralized before. And because we don't have an FDA who's trying to centralize our process, people have sort of developed their research procedures based on who their mentors were and what classes they took in graduate school and the ethics boards that they from their institution. So there's quite a variability in the way the same core principles and procedures are enacted by different behavioral health research teams. And behavioral health researchers are often engaging in a lot of high-level responsible training, supervision, and maintenance of all of their study procedures, but not conducting or documenting it in a way that GCP oversight boards like DSMBs would recognize what you're doing. So for example, the GCP makes a distinction between an IRB protocol and an operational protocol. And so the latter is like one big, like what used to be like when I did our DoD research, literally big, thick notebooks, printing out every single aspect of your research. My eyes were, the size of, saucers trying to figure out what the heck we were supposed to do when we first started doing DoD research with this expectation. That's really different than a way a lot of us, like we train our staff kind of as they come into to the lab. We have guidelines and we do a lot of onboarding. So it's not like we're not doing it, but we're not necessarily tying this to this study, right? But to meet GCP guidelines, you'd need to at least link all of your lab activities into your study's operational protocol. You'd have to have an operational protocol. You'd have to link to it. And really what they would prefer is that you just had a copy of every single procedure of your lab or center in that document. That's what they're used to seeing because they're used to these standard research centers with, physicians kind of popping in and out with their different studies. There are some unexpected procedures. I know that Barbara's on this call and Anna, who worked with me with our NIMH DSMB, where there were lots of things I didn't have the faintest idea I was supposed to be doing. So like you're supposed to have a signed and dated resume on file for every single staff person. You're supposed to have a Word document where you have like a table and everybody who comes to every training, there needs to be a sign off for each staff member who came to every training and the date. And so you can document every single person who came to every training. We, of course, had this in base camp because that's how we do things around here. And that was not a way to do things. When we were kind of reviewed by what they call a CREST team. I don't actually know what CREST stands for. I should have looked that up. But that's essentially an auditing team within the DSMB system at NIMH. Um, you're supposed to have very specific wording on consent forms that to me was substantively the same as what we were already saying, but we had to make modifications. And there's this really interesting thing about a protocol deviation as opposed to a protocol violation. A protocol deviation is a mistake. And in a lot of settings, GCP would presume that every mistake made by a staff person and every mistake made by a participant in your study, like they left some items blank on a survey, should be documented in a protocol deviation report. I was like, wait a minute, what? Like this was completely wild to me. And I was really shocked. So I did not, I think that's something that sometimes is going to trip you up. Um, Also, GCP did not apply to behavioral research through NIMH until 2017. So the trial where we really got tripped up was I think we got funded in 2015, started the trial section right about 2017. And so we didn't come into this with this as a plan at all. So again, what I'm sort of saying is that the lexicon, the framing is different, even though the concepts I think are pretty consistent with what we do already. Um, but you do have to do a lot of reorg for it. Um, and I think that it's really critical for studies that are monitored under GCP to be trained in this lexicon and standard procedures. So even if you want to do things another way, you are you have an operational manual that is what somebody would expect to see that like calls things out in a way that's like, we do it like this here, but we do it, it's here, you can find it, etc. I think this is an argument for independent versus NIMH level DSMB oversight for behavioral trials because I don't think the toxicity issues are the same. And and we're not doing research in at Fred Hutch or a cardiac center. And I think the issues we're structured completely differently. And your independent DSMB does not need to insist on all of these things that the institutional, like NIMH DSMBs do. Or that DSMB expectations should be revised to better fit behavioral health research practices. Okay, so that was internal monitoring. Let's flip to external monitoring. Um, so internal sort of the external monitoring is like when might somebody stop your study, right? So while we're kind of looking at there are internal problems that could lead a study to be terminated, like you're found not to follow study protocols, you determine there's a major conflict of interest that is not being managed, and the site and the university will not adequately manage it. That did happen to me once when I was on the NIMH trial, where after multiple attempts, the university would not pivot, and the DSMB said, well, then we're done with this study. Inadequate enrollment would be an internal problem that would potentially lead people to end your trial early. So the principle here is that it isn't safe for patients to be exposed to the research if you will not have sufficient power to come to a conclusion. This is kind of interesting in some of our suicide research because like with some of the research, people are getting treatments, often treatments that have been piloted or in previous research shown to be effective, that have some to no toxicity. So what exactly are we protecting people from? Very different than if you're gonna, give me an injection of some kind of medication that could have all kind of weird effects on me, right? But the reality is, if your enrollment is too low, your study could be stopped. And then there's external problems where there's a significant difference in important outcomes, and they're seeing that, so they'll often have you, they're blinded. So it's treatment A, treatment B. They can see treatment A numbers look different than treatment B numbers. So perhaps you're doing a study of depression, and um, the depression numbers look significantly different. And so the idea of a stopping rule was maybe we should stop this study now to save resources and stop exposing the control participants to control, because we know that this treatment is working. That's one rationale for a stopping rule. The opposite rationale for a stopping rule is we're seeing more suicide attempts in one condition than the other. We shouldn't go on enrolling people and exposing people to this risk. Whoops. So there are a lot of dangers to stopping a trial early. It turns out this isn't as good an idea as anybody originally thought it would be. So it is not uncommon to see that conclusions of efficacy or toxicity based on partial trial data are not supported if the full trial is completed. So like in situations where they debated, should we stop or shouldn't we stop, decided not to stop, kept the study going, and you did not see those effects continue. And in fact, they have this idea of random high that people think about in terms of these situations where that at the time people ask the question, should we stop the study, is a moment of sort of random in the up and down of the course of the trial. There was a moment where things looked really good, right? Or there's a moment when things looked really bad. You could make a random low too, right? And so they decide to stop the study, but essentially we've seen that some studies where they decided to go ahead ultimately found nothing. That this really was just a kind of random finding along the way. They've also done simulation studies to sort of test this, and shown that they can overestimate the effects based on when they choose to stop the study. And meta-analyses comparing trials stopped early for those that were not found the studies that stopped early tended to overestimate effect, right? Like that wouldn't be a surprise, right? If you stopped this trial at a point when there was a random high, it's going to look like your intervention was better than perhaps it actually would have been if you finished the trial. Sometimes the trial is stopped early, based on an outcome, but the outcome is a combined endpoint. So in cardiac care, that might be that your outcome is angina, myocardial infarction, or a heart attack, and death, or in our world, an ER visit, a suicide attempt, or death by suicide, right? Which we've done in some of our trial. The problem is that often the least patient important outcome in the composite is going to drive that outcome, right? So angina is going to be way more common than a heart attack or death, right? And so that's going to drive things, but then we're going to have a result published without knowing that much about what actually mattered most, which is the heart attack or death, right? Same with suicide attempt or death by suicide. So stopping rules, they also require a large number of outcome events before you can stop. And it's hard for low base rate studies like suicide to actually accumulate high numbers of events. The same would be true for cardiac, heart attack research too. It also matters when outcomes are known, right? So in a suicide trial, we often not only have a low base rate outcome, but the outcome might not be known for quite some time. And like, we do an 8-month follow-up assessment, and we haven't assessed them since 3 months. So in that 5-month period, they made an attempt. Maybe they made it 3.5 months in. It's quite some time since that attempt by the time we find out about it. And then so it's really hard to sort of be able to do that. So for these reasons, stopping trials early is now pretty uncommon, even though it was one of the original purposes for DSMBs. So what about suicide trials? So a couple things that you got to think about with suicide trials in particular, right? So what is an adverse event? So an adverse event is when it is based on these two concepts. Was the event expected to occur? And was it potentially related to the study intervention or the procedure? So expectation and relatedness. Many studies exclude suicidal individuals, and therefore suicidal behavior is not expected. So that um, kind of clears up one piece, right? So if in their case, they can sort of move on to the relatedness, but in behavioral health research, it's not so clear when something is related, right? Is the suicidal behavior occurring because of the study? That's what we would mean by relatedness. So even though it's really hard to determine, as opposed to medication research, it is the basis upon which this event is going to get evaluated. But if you think about this, right, the inclusion is suicidal thoughts and behavior, then suicidal behavior is by definition expected, right? So that's our world. In the face of this, some IRBs and DSMBs, like the University of Washington IRB, doesn't want to review all the suicidal thoughts and behaviors because it was expected to occur, whether or not the participant chose to be in the research. But some IRBs and DSMBs who are uncomfortable with overseeing research with suicidal participants will consider any suicidal thought or behavior to be an adverse event, and expect to review each event for potential relatedness and appropriate response. Even things like non-suicidal self-injury, which, as you know, is quite a frequent occurrence. So you can see how this could get exponentially out of control. So because it's very hard to determine relatedness, this is a lot of work per event, right? So just to be concrete, what if someone attempted suicide on the day of an assessment or a therapy session? Does that make it related? Well, how long after would it count as related? Given that they're in the study because of all kind of stresses and conflicts in their own life that parallel their research participation, how do we know it was the study and not something else? Okay, so in order to try to figure that out, we need a lot of details about each event and about what's going on at the time. And once you get into that level of assessment, you're actually changing your study's results, right? You are doing things that are different than the intervention under study, but that are directly tied to the outcome of the study. So we would not do a Prozac trial and sort of intermittently add, some other medication, because somebody's at risk in some haphazard way, but that's kind of how risk management tends to happen in these trials. Because these episodes are so frequent, the task becomes huge. And the criteria is problematic, as I just was describing. And whoops. So it's really just an enormous workload. I think it's also a problem for the DSMB members who aren't familiar with suicidality. They tend to have greater monitoring requirements because they're nervous, and so they're doing the same thing that clinicians are expected to do: monitor, 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 right? So they just ask for another table, and I have been guilty as a DSMB member of asking things like clinical worsening, which helped me not at all, but really took enormous time from the research team and us to figure out. So you have to think about the opportunity cost of this, right? This is all of the time that's going to all this monitoring means that those staff cannot be sure that you have sufficient recruitment for your study, be sure the follow-up rates are high enough. They can't check data in real time because they're caught up in doing all of this. Um, the staff get burned out, as staff on this call I'm sure could tell you. Um, and the procedures that we use to mitigate that suicide risk could be confounding our results. For instance, if we do more for the TAU than the experimental condition, now we have two different things that we can't untangle. Or if we do it for both groups and that's having an effect, which you'd want it to have, then you're reducing the sample size, I mean, the effect size left for the difference between experimental and control treatment. So this is sort of defeating the purpose of this expensive trial. And it's not clear that it's actually leading to better experience for the participants. So other things that they could be monitoring, and I'll come back to this in a minute, is things like, can they, people often not asked to share in a lot of detail their risk management plan. They should be perhaps asked to come to the DSMB with changes to their risk management plan if they need to, or the percent of these events where the risk management plan that everybody agreed to wasn't followed. So I think that we're also kind of constrained when we come to pragmatic and effectiveness trials outside of academics, because there's a lot of things that people would expect, like that you would just admit the patient if they're at high risk. This is not something that the study team can direct. It's too expensive for a lot of our participants. And there are a lot of potential increasing risk by the loss of things that can happen if you hospitalize somebody. In low resource and marginalized communities, there's a lot of typical responses for academic medical centers that just won't work. There isn't enough access to care. In the absence of the sort of preferred or lower access care, things turn into risk rescues that can lead to involvement of police because they don't have anybody else in that community to do this. Long waits, transfers to psychiatric facilities that are 6 hours away. These things are not often thought about by people who work in academic medical settings on DSMBs. Higher levels of care, and saying that you need to have higher levels of care is also kind of patriarchal, right? Like that's saying how this community should handle its problems, right? And it can, in small communities, lead to people either dropping out and also talking about the study, talking down the study, and then you're not going to be able to recruit people. Although I will acknowledge that there are community partners I've had where they want higher levels of care than I do, right? And so, community partnerships can go either way. So in terms of stopping rules for suicide research, we have to remember that our suicide attempts and hospitalizations are very low base rate. And if you could make conclusions looking at subsets of the data, why are you recruiting the whole sample, right? If we could just look at these numbers and eyeball the results, then we don't need statistics. We don't need to control for things. We don't need pretreatment data to control for effects between participants, etc., right? And of course, all the other problems of stopping rules I mentioned before. So if you, the expectation is you need a lot of events. So you often can't stop a study until kind of late along where you have overwhelming evidence, but it's really unclear what overwhelming is. And we need to continue to where you would be warranted in a stopping rule, but that might be close to the end of the trial. So it might be least helpful to the study to stop it so close to the end, right? So let me just give a concrete example of this. So this is a study by Annette Boutre and her colleagues in New Zealand of caring contacts. They were planning on 700 participants. They had power for that. 8 months into recruitment, they looked at their preliminary results and saw a larger than anticipated difference between the caring contacts and the control group. They were having recruitment difficulties and they decided to stop the trial early. And they were showing a significant P001 difference. Here's the actual publication. Because this stopping rule did not adjust for all of the factors that were adjusted for in the final trial, there was no effect. And the conclusion, in fact, despite the stopping early for positive effect, was that the study was a negative trial, right? Would this study have been a negative trial? They stopped at 327 out of 700. If they had 700, perhaps even controlling for baseline, they would have had an effect, right? So this is just kind of giving a sort of concrete example. The other thing about all of this is that because suicide is the outcome as well as the adverse event, you get into these kind of complicated blinding situations that don't come up when the outcome and the SAE are different, right? So you have to keep the research team, except the methodologist, out of all of the DSMB's oversight of treatment A versus treatment B, right? So that you don't break the blind, right? In a study of bipolar disorder, suicide is a measure over here. We can hide the results of the bipolar disorder, closely manage the suicidality, right? In a study of suicide, they're the same thing, right? So we've had problems where the methodologist is trying to play telephone back and forth between the DSMB and the research team, can't tell the research team all of what's going on because it might unblind them. And so we've definitely had miscommunications, and the research team is kind of, it gets messy, and I'm happy to give examples if somebody wants to reach out about that. And what can I say? Unintentionally, you can get unblinded. I got unblinded on one of my studies. I know other people have been unblinded just accidentally, like they were supposed to redact something out of a report that I was reviewing and they just missed it. And I was like, oh, okay, well, that's the finding. All right. That was not fortunate. So the last couple things I just want to say in our kind of final minutes together is, despite everything about this that sounds totally negative about DSMBs, they can really be your friend. I have a DSMB on almost all of my research. I like having a DSMB. Just like just in any other consultation situation with suicidal individuals, it can be really helpful to have independent confirmation that your study design, your risk management, your data collections makes sense. But be fair. Your DSMB really has to be independent, right? This is not about getting a bunch of friends who are just going to improve your study. Like, that's really not the intention. Not only is it not the intention because that's unethical, but it's also not the intention in the sense, I really want an independent group of people to say that approach makes sense, right? And if it's just my friends who are going to tell me and blow smoke, then that isn't helping me really very much at all. Because you have to keep reporting to your DSMB, it keeps you on top of a lot of elements of your trial and your data collection, and assures that if there's an issue with any of your methods or how you're collecting data, you can find it early in the trial and fix it. The other thing I want to highlight is that Greg Simon, who's just got such clarity and precision of thinking in many areas, including this one, collaborated with me on one of my studies to create an alternative DSMB charter that was based on very different standards, not that different, but different enough that it really made a big difference for us. And what he did was to develop set questions that he encouraged people to follow, right? So the DSMB was kind of being asked to answer each of these questions. So in terms of recruitment process, will the trial randomize and collect outcome data from an adequate number of participants to answer the study question? And we gave them a consort chart and our target enrollment graph to be able to say whether or not we were actually recruiting enough participants. Whoops. Hold on. Okay. The second question, intervention fidelity. Are the treatments and interventions being delivered with adequate quality? So in our trial, we assessed whether people were showing up, whether they were attending at least 4 visits, so they had some dose of care, and whether they were adherent on CAMS. So that answered that question. Question 3 was the adverse event question. And this is where the argument was made that we can't really figure this out from the DSMB's review of subsets of the data anecdotally, right? And so we needed to sort of decide, do we have a well-characterized treatment? Do we have any reason to think that this study will not will cause some kind of mental health outcome? And if not, then perhaps there's really not something to monitor here. It's not like some medication toxicity situation. So instead, what we were monitoring was, are the staff appropriately responding to the urgent clinical needs that arise? So we tracked that. And we separated past treated events from what we would call actionable events. So if we find out that a person's was suicidal because they went to the ER, what is the study actually supposed to do at that point? They already had a very high level of care, right? So we really focused a lot on actionable events instead of non-actionable events. We have a focus of trying to make those endless tables have as much useful information as possible by tracking, was this an actionable event, or were these all things we found up where they already had treatment? I still am ambivalent about how much we can actually learn from these tables. Our study had 43 pages of this. How much a DSMB member can actually understand out of that, I don't know. Question 5, evidence of net benefit or harm. So how are you going to decide if it has been proven beneficial or should be terminated? If you can't use like a risk event as that basis because that's the outcome. And what we did was looked at whether somebody had to be withdrawn from the trial. If somebody had to be withdrawn from the trial, then we really might consider that we're potentially harming somebody. And so we monitored that. But there's other signals that you could be monitoring. So I think given the time, I will stop there. There was a couple other slides I was thinking about, but I think this covered the main topic. I appreciate that folks have been putting things in the chat, and I'm happy to consult on if anybody has questions going forward. Thank you.